Public health interventions against HIV, tuberculosis, and malaria require precise targets. Without a diagnostic backbone, these diseases continue rapidly unchecked. Relying purely on observing clinical symptoms to guess an illness is known as syndromic diagnosis. When practitioners treat a fever based solely on how a patient looks, error rates spike. Powerful drugs are prescribed for the wrong diseases, wasting scarce medical supplies. And this target guarantees the pathogen multiplies. This pushes the patient into an advanced, unmanaged illness, requiring intensive hospitalization that was easily preventable. The damage extends far past the individual. Decades of this guess-and-check prescribing actively breed antimicrobial resistance across the entire population. Furthermore, when an outbreak occurs, health authorities cannot recognize or contain it, without a laboratory isolating and confirming the exact pathogen responsible. Without definitive laboratory data, clinical guesswork becomes the primary driver of wasted resources and preventable mortality. To solve this, we must stop treating the laboratory as a passive room. It is an active, district-wide data engine. The data it generates dictates two things: the exact recovery pathway for an individual patient and the macro-level numbers required to execute public health strategies. Operating this engine in tropical medicine introduces a severe logistical tension. You have to balance decentralized access to testing with strictly controlled quality assurance. Resolving that tension means you cannot rely on a single facility. You must engineer a tiered architectural network that physically connects distant primary care outposts directly to central hubs. By bridging this gap, the modern district laboratory functions as an integrated nervous system, generating actionable health intelligence. Building this network starts with a blueprint of the district health system. At the very edges are the most peripheral nodes, outreach community-based laboratories located within local health centers and maternity units. These outposts provide remote access to high-impact, low-complexity screening, like examining blood smears for malaria or checking pregnant women for anemia. By testing right where the patients live, these facilities intercept the disease at its source, well before the patient's condition deteriorates. Connecting these outposts to the center is a specimen collection and transport network, a vital circulatory system for the district. This system operates bidirectionally. Complex biological samples move from the periphery up the chain, while definitive test results flow right back down to the patient. Equipping this decentralized edge brings diagnostic power directly into the community, sharply reducing the number of patients who require costly hospital referrals. At the core of this system sits the district hospital laboratory. Its primary technical role is executing the complex, high-volume batch processing that peripheral outposts simply do not have the equipment to handle. Administratively, it manages the supply chain, ensuring those distant outreach labs receive standardized, reliable reagents on a strict schedule. It also holds a major public health responsibility, isolating and confirming high-risk pathogens before an official epidemic is declared. In this way, the central hub acts as a filter, escalating only the most critical data and severe medical cases up to the regional or national hospitals. By providing rigorous quality assurance and logistical support, the central hub validates the work of the entire decentralized network. With the structure in place, we can measure the specific output of this tiered network. Clinically, the immediate result is an early, precise diagnosis that identifies the exact cause of an ambiguous fever or illness. This precision stops the clinical guess-and-check method, ensuring that powerful anti-malarial drugs and antibiotics are only prescribed when the pathogen is actually present. The laboratory data gives clinicians the necessary parameters to differentiate between a standard, uncomplicated infection and an emerging, life-threatening complication. On an epidemiological level, the network continuously generates the objective data required for regional disease surveillance. Confirming a tight geographic cluster of Vibrio or Shigella in routine stool samples acts as an immediate early warning system. Receiving that alert allows the district health management team to shift their resources directly toward epidemic containment before the infection spreads further. The network takes raw biological samples and distills them into the actionable intelligence that dictates resource allocation for the entire district. However, this physical architecture will rapidly collapse without strict adherence to total quality management, or TQM. TQM operates on one unforgiving rule: an inaccurate laboratory result is far more dangerous than no result at all. When outreach labs issue incorrect results, clinical staff lose confidence in the system, bypass the laboratory entirely, and revert back to blind guesswork. TQM goes well beyond technical pipetting accuracy. It is a comprehensive framework of operational protocols. Logistically, it demands strict inventory control to prevent crippling reagent stockouts that force labs to halt testing. On the hardware side, it requires rigorous equipment maintenance schedules to prevent prevent failures or mechanical breakdowns in harsh environments. TQM is the invisible, mandatory infrastructure that keeps the physical laboratory network operational in resource-limited settings. The primary enforcer of this infrastructure is the District Laboratory Coordinator. They are responsible for implementing and updating standard operating procedures across every tier of the laboratory system. One of their most critical tools is the monthly Quality Control Day. A central biological sample is split into identical portions and given blind identities. These blinded samples are then routed back to the outreach labs to test the competency of the peripheral staff. This is known as external quality assessment. If the results come back inconsistent, the coordinator identifies deteriorating reagents, locates poor technical performance, and initiates targeted retraining. Continuous, competency-based testing is the only mechanism that guarantees clinical reliability across a highly distributed network. The district laboratory is the central nervous system of rural and tropical healthcare. By structuring the flow of biological data, health authorities move away from reactive clinical guesswork and toward proactive, precision public health. But despite the sophistication of this architecture, it is sustained entirely by human integrity and continuous education. The guiding principle of laboratory management holds true. Willing people make failing systems work, while unwilling people make working systems fail. Investing in the people and protocols of this integrated diagnostic engine is the mandatory prerequisite to safeguarding community health and optimizing medical resources.